So in my session I was co-sharing my table with main investigators in the field of small cell lung cancer. There were Charles Rudin, talking about basic research. There was also Silvia Novello talking about recent advances in immunotherapy, and Corinne Finn talking about talking about radiotherapy, and myself talking about recent advances in targeted agents. So my talk was quite challenging because as compared to non-small cell lung cancer, small cell lung cancer has been lagged behind in terms of the development of targeted approaches. So what I tried to do in my session is to show the audience that there is a lot of things to do. There are new agents there that seems that can change the landscape of this disease, and some of them that I commented on and that I thought are ones of the most important relevant is, for example, the antibody drug DLL3 drug conjugate, also called Robati. And we have now results of the phase 1 trial, and that demonstrated significant and meaningful activity in those patients expressing DLL3, which is a protein that is overexpressed on the cells, tumor cells, neuroendocrine tumor cells. And we had last year in ASCO meeting the results of the Trinity study, which is a study in patients treated with almost 2 lines of therapy. And in this study, their activity was not as high as they were expecting, with an overall response rate of 18% in those patients expressing DLL3. And right now, I think we have to change for the ongoing trials. There are 2 ongoing trials right now, phase 3 ongoing trials. The MERU, which is maintenance treatment after cisplatinum etoposide, and then we have in the second line setting we have the Tahoe trial, which is comparing the standard topotecan versus Robati. So both trials are ongoing, and we are waiting to the results to see if Robati can be a new standard of care in small cell lung cancer. I also talk about new agents such as chemotherapeutic agents, such as lurbinectidin, which is a marine-related compound. And in a phase 1 and phase 2 trial presented last year and this year in the ASCO meeting, they have demonstrated that it has activity, around 30% response rate, 20-30% response rate, and right now in combination and as monotherapy. And there is right now a phase 3 trial that has very recently, 1-2 months ago, finished recruitment, and is a phase 3 Atlantis trial in second line setting compared to topotecan, compared to lurbinectidin plus doxorubicin, and we are waiting for the results to see if this can be also a new standard in the second line setting. Other things that they were not strategically targeted therapies, but I think they are very important, is the use of immunotherapy. And as Silvia Novello remarked in her session, the standard of care in the first line setting of this disease has changed. And we have this year in the World Conference of Lung Cancer and recently published in New England Journal of Medicine, there is the results of the Empower 133 trial comparing standard treatment with platinum etoposide versus carboplatin etoposide plus atezolizumab in first line setting of the disease, and the trial has been positive for its primary endpoint, demonstrating an improvement in overall survival from 10 to 12.3 months, with a decrease of a risk of death of 30% in those patients treated with a combination of chemotherapy and atezolizumab. This is important because we have been in this meeting some new information about the use of immunotherapy as monotherapy in the second-line setting, and the results have not been as positive as they expected, such as the recently press release reported results of nivolumab in the second-line setting of small cell lung cancer. So I think it's important, maybe in small cell lung cancer, the activity of immunotherapy is completely different to non-small cell lung cancer, but right now it seems that the best option for these patients is to combine both approaches in the first-line setting.
Okay. By way of conclusion, can you tell me your thoughts, your feelings? What is the atmosphere and the expectation for people working in small cell lung cancer at this year's conference?
So I think there's a lot of enthusiasm. We know now, or we have admitted that small cell lung cancer is a completely different disease to non-small cell lung cancer, that we have to explore other different approaches in the disease. And I would say that now we realize that we have to explore combining strategies. Probably in small cell lung cancer, we do not have to go for one single approach, but we have to take the best of different approaches. New molecules using T-cell engaged approaches might be very useful, or also by the use of DNA repair inhibitors, for example, or checkpoint inhibitors combined with immune therapy. That could enhance the activity or the response of immune therapy. And of course, we have now the evidence that joining immune therapy and chemotherapy works in small cell lung cancer, so I think we have in front of us a sea of options, but we have to, of course, prospectively explore them and wait for the results of the phase 3 trial that I think they were going to be released soon next year in the forthcoming meetings.